Okay.
Should we start?
I think we should start. Good afternoon, everybody. We are really glad that you guys have chosen to spend the time with us. This is a mixed group, and what we're going to talk about today is bringing simulation to low and middle income countries with virtual resuscitation rooms as a global training tool. It will be a panel discussion, so make sure you keep in mind a few questions to ask of the group as we get to the end. My name is Kate Douglas. I am the Fellowship Director and Global Emergency Medicine Division Lead at GW. I'm going to turn it over to Maninder.
How's it going, guys? My name is Maninder Singh. I'm one of the SIM directors over at Jacobi, and I run the Simulation and Education Fellowship, and super excited to kind of join you guys in the panel discussion afterwards. I'm going to go ahead and let Debayan introduce himself.
Hello, everyone. My name is Debayan Guha. I'm one of the simulation faculty at Jacobi Medical Center. Very excited to meet everyone and talk about this project. Malika?
And I'm Malika. Ooh, this is a very loud mic, so I'm sorry. I'm Malika. I'm the Global Health Fellow at George Washington, and we will go ahead and get started. So just our disclosure slide. At the George Washington Ronald Reagan Institute of Emergency Medicine, we have partner agreements with multiple institutions across India. And very recently, we just received some funding from Inspire Group at IMSH to kind of continue this project as we move forward. The goal for today is to kind of talk about a new and innovative educational tool and how we applied it to our global space. We're going to talk about how we develop cases, talk about some of the simulation-related aspects of it, like debriefing, psychomotor skills, and Debayan and I will do most of the talking in the beginning, and then it'll be very open to discussion with the rest of our panel members here as well. So please have some questions. Before we really proceed much further, this is just 4 people on the team. There are a lot of people that were involved with this project. As you can see, it's multi-institutional. There's George Washington, there's Jacobi, Virginia Tech, and most importantly, our local partners in India. Without this project would not have happened. So this is me doing some teaching in India, and kind of to give a framework of how this project started, I have to first introduce our program at George Washington and what we do in India. And I know our global audience here might know that emergency medicine is a very new specialty, especially in the rest of the world, and there's a huge shortage of emergency medicine doctors. So here at GW, we're trying to kind of bridge that gap a little bit by training the next generation of emergency medicine physicians. The way that we do that is we have multiple partner sites, as you can kind of see here. We're kind of all over India, and it's a longitudinal 3-year curriculum, postgraduate training program, and it kind of incorporates both in-person teaching as well as virtual component as well. Now, we have been around since 2007, so a very, very long time. We've been doing simulation in our curriculum for a very long time as well. As you can see here in the right corner, we did ASAP Telesim Box, which was kind of born out of COVID, moving into our virtual space. Sorry, a little bit of echo. But one thing that we're doing is trying to always look at what are the new ways that we can deliver this education. So coming up with creative new ways to deliver education with our learners as we move forward.
So we have some cool tools. We have a long-standing collaborative curriculum with a bunch of local partners, and we want to make good education happen. So what's step number 1? Well, figure out what they need, right? If you're doing curricular development, your first step occurrence, needs assessment. We worked with the local partners throughout India to get an understanding of where their learners were coming from, what do they need, have they done SIM before, and what's the best way we could work with them. Developing an idea of what we were trying to do, our next step was try and build some new partnerships. We had actually a really easy partnership. We were co-residents going through Jacobi together. And as we went into our respective fields, right, me in simulation, Malika into global health, we were still friends. We're still colleagues.
Sometimes.
We definitely had some shared principles, ideals, goals, stuff like that. We're like, hey, I want to do simulation with you abroad. You want to think simulation isn't a weird, wacky thing to do. That was how our partnership came to be. But I am curious. how did you guys meet? Like, how did we at Jacoby and we at GW sort of make this work?
Take the lead on that first. So the answer to that is simple. National conferences, right? So same thing. It was at a different national conference, but we were giving a talk, we were giving a panel presentation on some of the simulation stuff that we do and kind of some of the work that was born out of COVID. We're doing virtual simulation. And same thing, at the end, kind of discussions were happening. A guy named Manu approached us afterwards and said, hey, we're doing a lot of stuff with India. Would you guys ever be interested in doing global simulation work? Super cool, awesome. He introduced us to Pete's person who runs their simulations there. She introduced me to Kate, and then it was just kind of some emails flying back and forth, a few meetings, and then eventually, once Dubai ended up matching into my simulation fellowship, and then just by chance, Malika ended up matching into Kate's global education fellowship. Then it became very obvious that this was going to be a much easier and more manageable project to start undertaking.
Yeah, and to add on to that, I think the key thing, and we've been talking about this, is that these like kind of organic relationships came together. There was partnership, there was shared vision, there's shared goals, and then what we established is an actual project with like a timeline and a plan, and we had two amazing people who had this kind of real, very kind of sustained commitment to doing the work that fit well within the context of the project. And so it wasn't by accident, it hasn't happened by accident, it's happened through like a lot of sustained work, and has been a very great example of partnership that has happened over time.
All right, let's go into the past a little bit. So we were in residency, right? This is a picture of our trauma bay, I think during an in situ simulation, right? 2019 we start. Jacoby Medical Center, large urban academic county program. Didactics, we're doing simulation once a month in the sim bay, in situ, and then in 2020, the world stops and we have to move all of our didactics online, right? And this is our first example, first experience trying to do simulation virtually over distance. And this sort of seed stuck with us. We brought it forward, and for my fellowship, I wanted to make that a cornerstone of what I was trying to do. I knew she was working across the world, and I was like, hi, can we make some cases that will work over a telecommunication software? If you're trying to make a simulation case, I think that there are three pretty important things you're trying to do here. First is have some sort of clinical experience. You need a patient, right? And if you have a patient, the patient has to have some sort of a reason that they're there. They're sick. They have a chief complaint. They're interactive. They have vital signs. That's why they're there. Then you need to have some learners. And not just learners. The learners have to be able to interact with the patient. Their actions are key to figuring out what they're learning from the clinical experience, right? Finally, like based on the actions, how does that feedback respond to the patient? Based on the patient's feedback, how do the learners then respond, right? You need to have a natural feedback loop. And so if you're trying to make something work on a distance platform, you need to have some sort of way of having those three things: patient, interactive learner actions, and feedback prompts. And so I introduced to you a patient that exists in Google Slides. All right, learners can interact with the patient, and based on their interactions, the slide itself will change. This is the VRR platform. All right, has anyone in the room sort of seen VRR, worked with it before? Cool. VRR, our people. The VRR was created by Dr. Sarah Fuhi, an EM specialist in Canada. It works really nicely based in Google Slides, so it's free, open access, easy, available for anyone to use. It's low fidelity simulation, and it works. It's been shown to be efficacious for pediatric resuscitation, bread and butter EM cases. And the big add for the VRR compared to, let's say, discussing a case over Zoom is this interactability. In the editor mode, learners can click through and drag and drop these interactive assets, right? You can take the clothes off the kid and find the rash, right? The learners exist on a telecommunication platform. Here we see some Zoom faces on the top, but they're interacting fully within the Google Slides space. And, just to sort of show how this feels, you ever walk into the, resuscitation, the resus bay after a code, and you're like, all right, there's some blood on the floor, the pads are open, I can see, some sharps that weren't put away, like, God damn it, you should have put that away, right? And all right, central line was placed, pads were open, cardiac arrest maybe, I kind of know what happened. Here I'm seeing intubation equipment, pressors, fluids, some meropenem over there, right? My learners in India performed a sepsis case together, working with one another, to great effect, keeping the patient alive. That's pretty cool.
And so how do we incorporate this tool into our existing framework? So our program at GW, we've been around for a while. We have a curriculum. Our learners are interns, and so this is a little bit of our brainstorming thought process for our curriculum. We're doing cardiovascular, we're doing trauma, we're doing peds. And now how do we align the teachers, our whole entire team, our learners into this and apply this tool into their education? And so we didn't want to take away anything, we just really wanted to add to their education. And this is sort of the impetus of our study. How do we compare this VRR tool to case-based discussion, which we were already doing virtually online? And is it really an efficacious tool overall? So the first question is, do the learners like it? Do they feel like it's meeting their personal and professional needs? And as a whole, as you can tell, they liked it. They felt more confident after doing a scenario. And overwhelmingly, the feedback is mostly positive. And this isn't really a surprise. You guys know with your learners, people love simulation, the people love interaction. It's a little bit more exciting and fun and informative than just doing a basic lecture. So how do we apply this into kind of a study format? First, we have to see, do our learners even really like these sessions? Are they gaining knowledge from these sessions? Is there something that's working for them? And generally speaking, with some confounding variables, they worked really well. And they are learning, whether we're doing case-based discussion or VRR, they're learning. And that's ultimately the goal for all of our innovative educational tools. Now, when we're comparing VRR to case-based discussion, except for trauma, and most of the cases you can see there's similar post-test knowledge scores to case and to VRR. And this kind of shows that this is a promising alternative for delivering simulation-based training. And while the knowledge gains might be comparable, what this doesn't really capture is the other things about VRR, the clinical decision-making, the teamwork, the procedural skills, working in an environment that's stressful. So those other things aren't really captured in this because this is just a multiple choice test at the end of the session. Now, we've been doing this for about 1.5 years. We had some challenges, some trials and errors, and these are probably some of the things that if anybody were to do this, you would come across. So convenience sampling, varying participants. I know our global health community has a lot of technological, logistical issues sometimes working with our global community as a whole. And these are just some of the other things: debriefing challenges, number of facilitators, time constraints, participation challenges. Now we're gonna talk about some of these things: technological, logistical issues, debriefing challenges, participation challenges, but we're not gonna address all of them, but please feel free to bring it up in the Q&A, and we will definitely discuss it as a whole as well.
All right, but the one thing we should definitely talk about are those technological issues, right? I mean, what's the most important thing? Can you see? Can you hear? Can you talk? Right? Because if you can't communicate, you're not going to learn. You're not going to be able to understand what the person across the room is really going through. So this is an example of the tips and tricks that we iterated on, class by class, month by month. How could we streamline a process to get a bunch of people all on the same page really quickly? Even with a streamlined process, we're still spending maybe 10, 15 minutes of our 2-hour session making sure that the audiovisual experience for our learners was as perfect as we can get it, which is 15 minutes of learning time, right? If you're just doing a lecture, everyone be quiet, listen, right? You're good to go, 2 hours will go by, right? But we felt that this investment in time resource for getting the audiovisual working for our students pays itself back in dividends. Once they can talk, once they can communicate, now you get a lot of those secondary effects, right? Now we can have teamwork and communication. Now we can discuss each other's decision-making, and that made it incredibly important. Moving on to participation, right? So for our active participants, we'd have 4 to 6 students working together, interns working together as a team, right? And sometimes what we're seeing, hey guys, case starts, a domination of the microphone, right? One team leader generally would be the one working with the facilitators, going through the case, while the rest of the team kind of filtered towards the background. What can you do for this? I'm not reinventing the wheel here, right? Just like in real life, if you're in the resuscitation bay, you need to have a role. Once you have a role, now it's very clear what you're here to do. We actively assign roles to our learners, team leader, airway, medication, procedures. And by defining these roles, it allowed our facilitators to gently call in learners who are filtering away, as well as offering the team leader a place to sort of be a little bit more quiet here. We're going to give another person a chance to participate. By calling on, let's say, the procedure resident to go through their procedure, engaging with their with the clicking and the moving around of the equipment on the screen, we're able to see their thought process, give them a chance to really shine. And we were able to develop a little bit more participation that way.
With our learners also, we're actually a really large group. You know, our intern group can range anywhere from 20 to 30 to 40 residents in a given Zoom session. And so not only do we need to engage our active learners, we have to engage everybody else. And this is true in real life too. When you have simulation, there are people that are passively observing, and then there are people that are participating. But how do you translate that into a virtual setting? So one of the things that we kind of discovered a little bit through trial and error is engaging in the chat group. So me as a facilitator, I'm asking everybody else questions, or I'm pimping them a little bit on knowledge. I'm commenting on the simulation and they're commenting on the simulation. And another key component in a global health context is what is different for them and what is their policies, what equipment do they have, and sort of having a robust discussion about the case as a whole. This didn't take away from the simulation because the people that are participating in the simulation, they're actually not seeing this chat. This is really for everybody else who's observing and participating in the passive way to really talk about what is going on.
All right, let's talk a little bit about lessons learned in debriefing the clinical encounters, right? So this is the Pearls Healthcare Debriefing Tool. Me and Maninder use it daily, right? We first, when you're starting as a baby fellow, you get that little index card, and you're reading it, and it's gospel. You're doing setting the scene, reactions, descriptions, analysis. And as you get more and more comfortable with it, you don't need the card so much, but you believe. So long as you follow the steps, you can debrief anything. You can debrief a wet paper bag. And so my first experience, I'm on this Zoom, case goes wonderfully, people are doing cardiac arrest, people are doing CPR, like it's a wonderful experience. We get ROSC. And so we go to the room, not the breakout room, but we open everyone back in to do the debrief. And I start very confidently, all right, we're doing our sim, this is a safe, psychologically safe space, everyone can talk. How's everyone feeling? And I get hit with that wall of silence. No one's saying anything. Crickets are chirping in the background. I hear a car passing by, right? And for the first time in a long time, I'm nervous. I'm like, oh, what am I doing wrong here? How is my debrief not connecting with the learners? How am I not getting the point across? Debriefing any large audience over Zoom has its own challenges, all right? There's not this crosstalk. There's a little bit more of an awkwardness to it. But there was something else. There was something that maybe the steps of my gospel weren't quite addressing. And so the question becomes, right, what are the changes we need to make, and why are they? What is the underlying reason behind them?
And so why are we hitting that silence? I know in the global health community, this is not something that we're unheard of. We experience this sometimes with our learners when we go to a different environment, a different country, or even just a different institution. And so is it because they're interns and they are scared to say something? Is it because they can't talk, even though we just addressed all those audiovisual tips and tricks? Or for us and our learners, we discovered something called power distance index. And for those that might not be familiar with that term, it's kind of a formal way of saying how formal are they, how hierarchical are they, and how does that affect their learning process? And so what we discovered, and it shouldn't be a surprise to a lot of people, they were hesitant to speak up. It's a very hierarchical culture, and so they felt uncomfortable voicing what mistakes they made or things that they might not know from the debriefing and the virtual simulation. And so what we had to do was figure out how do we meet them where they are and addressing this maybe cultural context in a slightly different way. And what debriefing methods could we do differently that addresses that maybe would not work in a Western world as well.
All right. Thankfully, we're not alone in this, right? Like, I was able to go and ask, like, Hey, am I doing stuff wrong? Kate, what do you think from your experience? Tanya, what do you think from your experience? Malika, what do you think from your experience? Right? We were using the full toolbox. How can we get people talking? So let's go to reactions real quick, right? How do you feel is not going to work, right? Here's maybe a place where you don't feel comfortable being the intern lowest on the totem pole, telling a superior, quote unquote, how I feel honestly. And so our solution was piecemeal. To start, continue setting the scene. I feel, right, by modeling from maybe a hierarchical position, how I feel, it's okay to talk about it, right? Maybe asking for a one-word answer, not an open-ended question. Do you feel good? Do you feel bad? Do you feel like that didn't go well? Do you feel like we should, move on? And eventually, as we did this month by month, we opened up people to the idea that maybe there's more to discuss about reactions than initially met the eye. Now we're getting a little bit more of a discussion. Still maybe not fully emotional. Maybe it's a little bit more technical. That's true of our learners too, right? If I was to ask a bunch of residents in my program, how do you feel? They'll be like, the case was good. I'm like, that's not a feeling. Moving on to sort of further points in the debrief, I do want to highlight one thing real quick. So there's a part of this where you're talking about the shared facts of the case. Really easy on VRR. I copied the notes and I pasted it there. But for the analysis of the case, a lot of things that we use is a learner-centered analysis, right? This is the age-old question, what do you think went well? Okay, well, what's one thing we could do differently the next time? Another set of open-ended questions. And while we were able to get a little bit of traction on that, for example, maybe to echo something Malika said before, asking about, well, would you do this in your hospital, right? Going back to that idea of like hospital systems. Your plus delta was a little bit more stilted. And so what we recommend, at least to start, is the idea of focus facilitation, right? The idea of focus facilitation is a facilitator using their own observations and judgment to ask direct questions of the learners in a way that opens up their frame of reference, their frame of mind, allows them to speak on what they're feeling, right? So for example, going to my first slide, right? I saw you use meropenem. I think that's a very broad spectrum antibiotic, maybe not my first line in a community-acquired pneumonia. And so I'm curious, what do you know about antibiotics and which ones you should use, right? This kind of direct question allows the learner to be like, oh, there are options. I do know something about antibiotics. I can talk about that. It's a direct question, so there's nowhere to sort of hide, like with an open-ended question. And our learners actually had so much to say. Once you turn the spotlight on them, they knew so much, they're ready to share. They just needed a framework to do so. There are some challenges with focus facilitation. It can be hard to come up with these questions on the fly. How did we address that?
Well, kind of echoing that, WhatsApp. Everybody uses WhatsApp. I know we do, especially in the global health context. That's our primary mode of communication. And so for us, that was also our primary mode of communication. For our focus facilitation, we just created a WhatsApp group. And kind of pushing this further in a cultural context, a global context, there are a couple of things. Not only are we asking, what do you know about meropenem and what antibiotics? You have to ask, in your environment, what's different? What's your antibiogram in India versus my antibiogram in Washington, D.C.? And we did a lot of this discussion on WhatsApp. So for example, I didn't know what Levopil is. Does anybody know what Levopil is? It says Keppra. Answer right over there. Very good. So I didn't know that. And so I'm asking my fellow facilitators, what is Levopil? And the key component of this, I think, is that one, we're keeping in mind whatever medication differences, environment differences, and we're talking about that together without breaking the simulation also. Sometimes when you're doing this in real life, if we're talking, people are just standing there. To do that on a Zoom is way more painful because then there's just silence or it's just us talking to each other. So this was really crucial for us to all be on the same page, talk about some of the differences, address some of these like global context issues that might not have been there before. And another key component of this is the pre-huddle. So I know for our simulation people here, you're very used to doing a pre-huddle before debrief. For us, that pre-huddle was WhatsApp. We had to be all on the same page without really pausing the Zoom, pausing the simulation. And here we're talking about, okay, we have to talk about these parts. They missed this. We need to talk about these assessment-related questions, this material, and it really kind of allows for a shared mental model of thinking for our debrief without having to incorporate anybody else in a Zoom format.
I mean, think about our debriefers, right? This is like your advocacy inquiry questions just being beamed directly into your head. My observations are coming to me. What the question I'm trying to ask is coming to me. I'm ready to go and see what the learners need to know. One other thing that Malika was speaking to before, right? There are these secondary benefits of doing simulation, right? More communication, other learning objectives that you can hit other than just the pure knowledge, like from a lecture or a case. One of the important secondary benefits I believe in from the virtual resuscitation room is the idea of technical skills, right? It's really difficult to teach a procedure in a lecture. It's really difficult to teach a procedure over the computer. You can do it. I mean, there are videos. You can watch it on YouTube, sure. But I think the feeling of working mentally through something, moving something around, stays with you in a different way. We were very, very focused on at least doing one procedure per case. So this comes right out of the box, right? This airway box was developed. It's on the VRR website. This is what we started with, right? How can we intubate on VRR? So in an oral boards case, you intubate the patient. How do you do that? I do it like this. All right, patient's intubated, right? Maybe I didn't ask all the questions I wanted to. Here I have a way of sort of promoting the learner's thought process. Go to slide 5. We're intubating this patient. Which equipment do you need? Right? What backups are you going to use? Why are they important? Right? We're promoting this idea of going through like what could happen in an intubation before copy and pasting those assets back into the original room to perform the intubation. As we got more used to using the VRR software, we started branching out and making our own procedures. Here you see our learners working through lumbar puncture, right? They talk through what they're doing. They don't really describe the anatomy right. And so we've offered them some in the sim advice on where to put their hands, what to look for their anatomy, and their landmarks. As we move forward, we started thinking more about, can we throw in some curveballs, right? Here is an obstructed view, right? A difficult airway, right? It's important for our halo procedures to be incorporated, for common complications and troubleshooting to be incorporated, just to give the learners that feeling that, hey, this isn't the first time I see it when it comes up in the sim lab or the real world later. And why incorporate all this? Data from the mental rehearsal literature shows that even the cognitive rehearsal of steps lead to better outcomes in the sim lab and in the field, right? VRR can be the first pass for all these learners before they're expected to do so in a much more stressful environment. And so I want to just take this final moment to just share a testimonial from Dr. Vineet in the corner over here. We're running the case. We're intubating status epilepticus. He does a great job, right? Walks through the procedure, talks through it, intubates, excellent. And in the debrief, we're talking about the procedure, and he offers, sir, that was my first intubation. And I really felt good about that, right? Because calling it my first intubation, owning that procedure, even though it was like a Google Slides-based classroom, I really hope that stays so that the next time he's doing a simulated case, first time he's doing one in real life, he's like, all right, I feel prepared. I know the steps. We'll see what happens from here, but I feel good. And VRR was a part of that. All right, thank you very much for your time. We're ready to move on to questions.
Yeah.
Anything else?
I don't think so. I mean, this is open forum, open discussion. We definitely have some just talking points that we can talk about, but does anybody have any immediate questions before we start? Christy?
I'll start with one. I think
There's a question. No, go for it, Christy. There you go.
Thank you. That was very interesting, and kudos for your hard work and really positive outcomes. So 2 questions. One, I was curious about the pre-post test or evaluation used, and probably you're planning to publish that at some point. I think many in the room would be curious about that. And then my second question, I mean, I know a little bit about this from Kate, Dr. Douglas, but how you incorporated international partners there to sort of address some of the cultural sensitization, local methods, and this kind of thing.
I can talk about the pre-test, post-test. So our learners already use Rosh Review as a part of their kind of curriculum, just like we do Rosh Review with our residents. So what we did was kind of pull from the Rosh Review question bank and about those topics. So if I go back to the curriculum for pediatrics, I would pull the Rosh Review pediatric questions from there. And then they would be that same pre-test and that post-test. We actually delivered the pre-test at the beginning of the intern year, so to have some baseline idea of where they stand. And then every month when we did this session, we would do those same questions after that session to see. And so in some ways, they should have been familiar with the questions already because it was Rosh Review, it wasn't a brand new thing. But I will also say Rosh Review questions are fine. They don't really capture everything at the end of the day. And I think one of the challenges that we faced with this study as a whole is that Rosh Review questions aren't really evaluating all the aspects of these tools, kind of like the learn, mental modeling, procedural skills, all of these things. Yeah, go ahead.
And I'm happy to speak a little bit about local partners. I don't even know. Is this working? Yeah. So, I mean, we've worked with partners in India for a very long time. In the context of this, I think that a couple of key things. One is that it's both like knowledge delivery, but it's also a lot of exchange. And so at the time when we're doing it, like the interaction in and around like, what is that drug? What is this, what is this intervention? And also the reality that the chat is going on because the learners are from different sites. And so we have learners from different places. So their actual place of work is different. And then the facilitators, I'm not sure that like the amount of work and people that went into this is pretty intensive because we had multiple facilitators. And the facilitators are also from different locations, including international partners as well. So like Tom was on there and he's from the UK. So there's a kind of back and forth and also an acknowledgement at the same time. The standards are the same, but like if somebody does or does not have this one thing, then we'll address it in real time with a conversation around that.
Thank you. Larry Melnicker from NYP Brooklyn Methodist. Just to follow up on the other question, you do a pre-test, you do a post-test. Do you do a follow-up retention test? Because editors really care about that if you want to publish your data.
Yeah. Do you want to answer that? Okay, I can answer it. So it's a good point. Our learners actually, they're this is like a residency for them, right? So they are doing exams at the end of June. They're going to be tested on this knowledge. Our goal is to kind of see if they retain, as we move forward. This has been a year where PGY1 learners, we're kind of see maybe as PGY2 learners, do they retain this knowledge? I will say there's a bit of a challenge, right? We have a ton of learners. One of the challenges that we faced is that sometimes they would be in some sessions, but not all sessions. So it's a little bit hard to capture that kind of like follow-up data in the same exact way. Learner A is not always present every single day, just like in our residencies, they're going to 70% of conferences, and it's not necessarily 100% conferences. So getting that follow-up data is a little bit challenging in our specific context. Our goal, though, is to kind of see if they do perform better as PGY2s with our exams and other ways of evaluation that they will see improvement.
Yeah, so just to echo kind of what Malika's saying, definitely with the retention, but as Malika alluded to earlier, it's a little bit, what we noticed was, it's a little bit, obviously, Rosh Review questions are multiple choice questions, right, geared towards a discussion-based setting. So in the sim, there's a lot of intangibles that we haven't been able to figure out. So one of the earlier disclosures that they mentioned is we're actually trying to see if there's a way to kind of measure any of those intangibles. So the Inspire group is helping us by purchasing a couple of mannequins that we're then going to ship to them and then try to see is any of kind of these case studies that Divine was talking about, the first time intubation, are any of these skills translating to a higher procedural competency checklist, et cetera. But more on that to come.
Rita Manfredi, George Washington University. Just a quick question for you. Obviously, you're evaluating your learners. I'm curious if you as trainers are evaluated. And I came in a little late. You may have talked about that before I got here. but what type of evaluation are you going through as facilitators, and does that happen at all?
So, amazing question. I don't think we're actually doing exactly kind of what you're asking. What we are doing is we're doing iterative kind of methods for ourselves. So we've got a large kind of learning document for ourselves in terms of lessons learned, and kind of back to the point that Kate was talking about earlier, a lot of those medications, like we're learning the differences. So we've got just like the normal part of this medication is common, this is the different words, so that we can adjust our Google Slides so that they'll be a lot more culturally appropriate. But at the same time, we're trying to get a running document so that as we train the next group of facilitators, then we're kind of helping them with the iterative changes of here's what we learned, here are lessons learned, and so that every new facilitator who joins and helps us is at the same baseline level.
Yeah, I'm going to add on to that just a little bit. I think it's one of the things we see with our group, because this is one example of some innovative education stuff that we're doing virtually, is that it is, and it's not to be kind of the importance is not to be underestimated, the amount of learning that as a facilitator you have in terms of using the tool, in terms of using the Zoom, in terms of understanding where your barriers are in terms of cultural context and communication. And so many of the steps that were so well described by Devian and Malika are steps that were learned by facilitators. We are getting not a ton of, we have a balance too between the survey and survey and then survey and then survey. And that is really a dominant theme too. Like we don't want to overdo or underdo that. We're getting a lot of positive feedback from the people, our learners overseas and our faculty overseas about the positive kind of overall sentiment in and around this project itself. And that's kind of where we've kept it for now.
May I just add one thing to the surveys? I definitely think, I was trained and taught that all of our facilitators should get feedback from their learners, right? And so something I've been noticing with the positive survey data is I feel kind of weird that there's not that much negative stuff, right? And I wonder that even if anonymized, the desire to, I don't take it personal. It's not criticism. I want to know what I can improve on, and that idea might not be there in a way that I understood. So my survey itself might not be created the right framework. I don't know if anyone in the audience or Kate has anything to think about that.
So yes, this is great. You're making this a discussion. So a couple comments. One, so I teach a grant writing course for African scientists, very similar culture, like tendency towards positivity bias. So one thing that helps is having an external person evaluate you all, come in and make sure that it's definitely anonymized and visually and obvious, evident that it's not coming back to you all. Because I agree. For example, in our surveys, for example, on a weekly basis, we get a lot of positive feedback. But when I have someone and actually remove myself from it, objectively evaluate our case, actually more in a discussion setting, they got more candid feedback. So that might be an option. In some way, remove yourselves from it very clearly and possibly putting it in more of a focus group setting. And then I just had some thoughts or suggestions or feedback, if you've thought about this, I don't know, regarding evaluating the effectiveness of the intervention, because I would be very interested in this. And I'm not a SIM person, I'm a global health person, and I'm an implementation science person, but not SIM. But I'd be really interested in thinking about what the core components are that make it successful, right? And so I think there could be a way that you could either using the SIM literature or creating your own hypothesis around what are the core components that do make it effective, and have someone objectively evaluate that per session, and then you could actually present some really impactful stuff for the rest of us in global health that are thinking of this kind of thing. I mean, it could be, I'll give you some suggestions off the top of my head, like the length, duration of the course, level of interaction, which could be measured by some way you think of it. It could be the complexity of the case, like there are 4 or 5 objectives versus less objectives, complexity of the severity of the patients, more procedures. There are probably a number of things you could think about. I think there's a way you could objectify that and evaluate it.
I will say one thing that we're doing, and Meninder kind of referenced this, is that with those mannequins that we're going to take there, we're using a standardized checklist for intubation. So there's tons of published things about standardized intubation checklists. And so we tried to use that both in the VRR, also in person when we go in person and teach. And so I think that's one example of seeing objectively, is this working? Is this is this skills that we're teaching them translating into an actual thing? Now, it's not a person, it's a mannequin, but it's still that mental rehearsal that we were talking about, going through the steps with a standardized intubation checklist. Is it working? So those are really great ideas. I would definitely would like to hear a little bit more about that. But I think that's one of the challenges is that how do we translate this into I can't speak anymore, but you know what I mean. Yeah. Objectivity of, procedures and knowledge and all that things. A lot of the challenge with I was picking the Rosh review questions, and one, we're constrained by time. So we do this 2 hours once a month within our curriculum. And you're trying to address both like the feelings part of it, the knowledge part of it, the procedural part of it. It is a little bit challenging to kind of get all of those components of the case as a whole. And so one of those things is that the Rosh review questions, if you talked about it in the sim, then they're going to get it right on the answer. Like if you pointedly be like, okay, what is the narrowest part of the airway, then they're going to get that answer right on the multiple choice question. If in the debrief that doesn't come up naturally for some reason, then it might be a missed question. But is that because they didn't do well on that intubation? Or is that because it didn't come up in a natural way in our debrief? So that was one of the challenges that we kind of faced throughout the process, is how do we address both the knowledge things, the feelings things, the teamwork, and all those things, and objectively evaluate those things.
Yeah, I guess I can talk a little bit about some of the one of the questions you asked there about like evaluator feedback. I've been one of the evaluators for this, or one of the facilitators, I guess, like debriefing. I mean, it's definitely hard to get feedback from the learners. I mean, even though it's anonymous, there are some like hierarchical issues there where like there's a much bigger like, I guess, like hierarchy there in like the medical system. So like, we come in, we try to be friendly, we introduce ourselves by our first names, and they call us doctor, and they're like, yes, thank, and like you give them, like, oh, that was a great job, and they're just like, thank you so much, and you're like, you just almost feel awkward that it's like they're taking it as seriously as they are sometimes. So I feel like we get a lot of positive feedback, and I wonder even when it's anonymous and they've never even met us in person, it would be very hard to get feedback from them that way, We like sometimes what we do often is like, especially the first several times when we bring a new facilitator in, is we have someone who's done it several times, like kind of watch and give that person feedback afterwards. We kind of debrief our debrief. Very meta, I know. But some of the stuff that whoever that was over there who was, I guess, suggesting like more objective ways, like bringing in another party, I think that could be pretty interesting.
Sometimes you have to beg people to be critical of you. I've been at my shop for 30 years, and I'm friends with so many people, and I definitely have to beg them to complain about my department so that I can make it better. And they think it's weird, and maybe I'm weird, but you may have to be very explicit and say, how can this program be better? Either you guys tell us how to make it better, or it's not going to get better.
You guys want to maybe go pull the challenges slide back up to promote some more questions?
Have people done virtual teaching in terms of procedural training?
I know the global health people definitely have, so. Yeah.
What have you done? How have you done it? How has it landed?
You guys had just on a much smaller scale, use virtual resusc room to start doing some intubation basics, do spinal tap for a program that we work with at Mission Hospital under the world.
Any challenges that we were not putting up there that you came across?
Covered a lot of them, especially the over gratefulness and trying to get them to be critical tends to be something where we're trying to really figure out what they didn't grasp from it. But I think one of the biggest things at first, which I came in a little late, I apologize, was getting the initial participation. It's the technological limitation, who can actually see, who can interact with the program, and then teaching them about it, getting them to actually utilize it like it's a natural patient.
Takes the mind, the suspension of disbelief, that psychological safety.
Right. So what I did actually, I had a separate session. I said, okay, this is the system we're using. We're gonna, instead of right before the case, I said, all right, everyone, we're meeting this week. We're gonna talk about how we're gonna do this for the coming month.
I like it. We did that kind of similarly, but we did it for all of the learners and their work on orientation. So the other guy kind of came around in orientation month, just on behalf of our residents. We did it during that time where we did just a session of just playing with the
The- Yeah. The other thing I was going to say for like the psychological safety, and we don't really have a slide on it right now, but we tried to kind of create a safe space every single session. So part of that audio visual tips and things that took 15 minutes out of every lecture, we also had like, this is a safe space, Las Vegas rules, nothing's gonna matter, it's not gonna be evaluated by us. This is truly just a learning experience. And I think we had to emphasize that every single session. It wasn't something that we just did in July. We literally did that monthly. And I think by the time that, now we're in the month of, it's May. Yeah, it's May. They're a little bit more comfortable. And they're a little bit more engaged because we've been doing this now for 12 months. And so I'm hoping in the future that this will be less of an issue, both with obtaining objective feedback and participation and engagement, but it definitely required a little bit of trial and error on our part in the beginning of how do we figure out to make this a safe space for them? How do we get them a little bit more engaged? Part of that really is doing that every single time, every month with them.
I'm actually feeling about it the other way. It's about to be July soon, so I'm really ready for them to all get quiet again. Those slides come right out of the box as well. Like use VR before, you sort of like they've designed a roles slide, a cardinal rules of sim slide, but everything is editable, right? So we found that some of the roles we wanted to change, we were able to go right in there and change them. Some of the ways that we wanted to phrase the cardinal rules, changing some of the language helped it land better.
Yeah, I just want to add on too. I think our GW programs, our partnership programs, have been going on for a very long time, which has given us kind of like a workshop to practice things. I really look back and think pre-COVID, we were not doing this, and then COVID happened, and then we started doing this, and then now it has really allowed us to really explore some different ways to reach more people and to really think about ways to get this kind of thing to scale. And so that's really like, there's a lot of work. I keep telling these guys, I'm like, don't underestimate the amount of work that went into doing this and that goes into every single session, because it's prep, it's like adjusting the case, it's thinking about it, it's actually doing the thing and being very, very intentional about those steps. And at the same time, it takes practice to do it for the participants, it takes practice for the facilitators. And at the same time, it's going to it is a thing that's going to allow us to reach more people, to help with skills and knowledge and all kind of communication and all of the acquiring of all of the things that then will hopefully translate into clinical care delivery. And so that's really kind of hopefully for the SIM people, the global people, everybody in the room, like thinking, okay, this is kind of a pilot, and we hope to keep growing it, and hopefully we can reach more people to really reach more patients.
The other thing I would add to that is, especially for the global health people, we're kind of in an environment where it's sometimes challenging to reach the people you want to reach. And we are doing a lot more virtual teaching and virtual learning. And like VRR is one tool. It's a really great tool. It's working well for us. But you can develop other things and still apply some of these same principles of cultural context, like knowing your learners, knowing your environment, engaging in discussion, addressing some of those power index issues. Like it doesn't matter what tool you use, you're going to have to address those issues. And I'm hoping that as we move forward in the global health, and we're doing a lot more virtual just because of the way of the world, that these kind of techniques and thoughts are helpful for those.
The last thought is just on gamification. So I know it's in education literature for sure, even though I'm not, again, that's not my main shtick, but it can help whether it's like your team having teams for your different sessions. You could also gamify the feedback too. Actually, this is something I'm gonna take away from myself as I'm thinking about this. So you could gamify and say like the team that gives like the most feedback will get an award of some kind. So or gamify like in the sim session the most participation. I mean, you don't want people like unnecessarily speaking up, but so gamification is.
We try to give reward points every now and then. We can't do it every time because, but if you participate in the chat a lot, then you get a shout out every single time. So it's you raise a good point. I think gamification is also a little bit the future of simulation and learning a little bit. But it raises a really good point of how we could incorporate that into feedback as well. I don't know what time it is.
Yeah, keeping track of time, I think we're just at the end of our session, so unless anybody has
QR code? Let's just switch to the QR code slide.
Oh, yes.
I just wanted to because again, a lot of this has been done by Dr. Sarah Fouhy. Her website is fantastic. You can just Google virtual resuscitation room, but I included it as a QR code. So if you guys want to see the demo, see what it looks like, get to know the platform a little bit.
It is an
also
open
available.
access tool, so yeah.
Thank you guys for coming. Appreciate everybody kind of making it a lot more interactive and not making it super boring. So thanks.